Good afternoon, everybody, and welcome to this webinar on incentive schemes for pregnant women who smoke. I'm Hazel Cheeseman. I'm Director of Policy at Action on Smoking and Health, and I'm going to be chairing this afternoon's webinar. So I've got a few bits of housekeeping and then a couple of slides, and then we will go into our excellent presentations from our two speakers. And then we have half an hour for Q&A at the end, and we'll be joined by some more experts for that Q&A session. So, first and foremost, if you experience any technical problems during the webinar, you can use the chat function on the panel on the right-hand side of your screen to let us know. And John and Vicky will try to assist you and sort out any problems you have. If you have questions during the webinar, and we very much want to hear your questions, you can type those throughout the webinar. You can start doing it now if you like, in the question tab that's also in that right-hand side of your screen. Only we will be able to see those questions, and we'll put them to the speakers when we get to the Q&A session. We're also recording the webinar, and it will go online, so you'll be able to share it with colleagues and others that are interested. Right, so we will go straight into the presentations from David and Fran shortly. I'm just going to say a couple of words. Just to remind me to tell you to type the questions in. Please don't forget to do that. First of all, just a very quick introduction to the Smoking and Pregnancy Challenge Group. Hopefully, most of you will be familiar with us. We're a coalition of organisations who've been together since about 2012, working to reduce rates of smoking in pregnancy. And we've got various policy reports that we've produced that are available on our website. And we've also done quite a bit of work to produce resources to support you on the front line, and I think my next slide has a link to where you can go and find some of those resources. And if you're not already signed up to the information network, I will urge you to email us and we can add you to that network, and we are regularly sending out emails with links to resources and things that can support you in your activity. And the link above there will take you to where all the other resources are that the Challenge Group has produced in relation to smoking and pregnancy, and it also links to resources produced by some of our member organisations and Public Health England and others. So, yes, and we have another webinar in our series of webinars, the last one coming up at the end of April, one on health visitors and relapse prevention. So do email us if you would find that interesting, or indeed forward it to colleagues if you think other people would find it interesting. So before we go into David's presentation, I just want to say a few words about incentive schemes. The reason the Challenge Group has been so interested in incentive schemes for pregnant women is that we now have a really quite established evidence base, which we'll talk more about through the webinar, that these can be effective. And we really need to find fresh new approaches to address the stagnation that we have in smoking rates among pregnant women. You know, we have this disadvantaged young population of women who in many ways face more barriers than they do facilitators in managing to quit smoking during pregnancy. And these schemes need to build on evidence-based care. They're not a substitute for implementing NICE guidance, but where they are done well, they are clearly adding value and allowing us to reach a larger population of women and help them to quit smoking. We are going to be publishing a briefing, an evidence into practice briefing on incentive schemes, which will be distributed through the information network, and hopefully it will add value to the conversation that we'll have today. And so if you would like to receive that, then definitely sign up to the network or email us at the Smokefree Action email address on your screen. Right, I shall go straight in then to our first speaker. Professor David Tappin is Professor of Clinical Trials for Children and, David is Professor of Clinical Trials for Children and an Associate of the Institute of Health and Wellbeing at Glasgow University. And David is going to take us through the evidence base around incentive schemes and talk in particular about the programme that he was involved with. So over to you, David.
Hi, thanks very much for inviting me. Can you all see the first slide?
Yeah, we can, David. That looks great.
Yeah, okay. So I'm going to talk about financial incentives. I hope I apologise at the beginning for talking a lot about what we've done as far as this is concerned, but I've worked for the last 10 years with Professor Linda Bald. I'm at Glasgow University, and she's at Edinburgh University. She's the chair of public health there. So what I'm going to do is to talk about smoking in pregnancy, which you'll all know a lot about, but I hope just to add a couple of things. The evidence base for incentive schemes in pregnancy, as I say, is largely based on the work that we've done. Looking at the context for a successful scheme, again, looks at what we've done and what we're doing at the moment, how schemes could be enhanced. We work with a group in Manchester who are undertaking a financial incentive scheme at the present time. And what evidence tells us about why schemes work. So I'll give you some information about that related to Glasgow, which was the site of our first trial, but now has set up its own scheme like Manchester. So smoking in pregnancy. Now, first of all, I want to talk about mothers, because everybody talks about the damage that happens to the babies from smoking during pregnancy, but what's the big plus for mothers if they manage to quit smoking during pregnancy? And this is just a study done by Sir Richard Doll, and it just shows that if you're 25 to 34 years of age and you give up smoking, you're probably not going to lose any lifespan. So if you smoke throughout your life, you lose about 10 years of your lifespan. But if you've given up by the time you're 34 years of age, you really don't lose any of your lifespan. You get away with it. And similar from 35 to 44 years, you maybe lose a year of life if you give up towards the end of 44 years, but you're pretty much get away with it unscathed. And this is the childbearing period. So what this means that if women can give up permanently, starting in pregnancy and then from then on, they're likely to not lose any lifespan, whereas somebody who continues smoking probably loses 10 years of life. So that's really just puts it in context as far as the mother's concerned. 80% of women in the UK have at least one baby. So if you like, pregnancy is an opportunity to help nearly all women to quit smoking before their health is permanently compromised, before they've ruined their health from smoking. And as I say, if women quit permanently during pregnancy, compared with not quitting at all, they'll live on average 10 years longer. So there's a lot of evidence around babies. I've just published with my colleagues a study which shows that perhaps up to a third of small for gestational babies are attributable to the fact that the mother smoked during pregnancy. 20% of sudden unexpected deaths in infancy, 10% of stillbirths, 5% of early miscarriages, and 7% of all premature births are because the mother smoked during pregnancy. Hospital admissions for the babies and children, so 7% of acute upper and lower respiratory infections, the admissions for those are because the mother smoked during pregnancy, as are 10% of bronchiolitis admissions, 7% of asthma admissions, and perhaps surprisingly but well documented that 12% of admissions for bacterial meningitis wouldn't happen if the mother hadn't smoked during pregnancy. And probably more important than all of these is the fact that parents who smoke, so often it's the mother and the father smoke, they can spend £3,000 to £5,000 a year on cigarettes. And what this does, it's been calculated that it pushes 400,000 UK children into poverty because the parents spend part of the household income on cigarettes. So it has a huge effect on the children. If we look at smoking in pregnancy in Scotland, where I live and work, you can see that overall from 1997 to 2018, there's been a reduction, which is great. But you can still see that there's a large difference between the most deprived groups, who are very commonly smokers, or much more commonly smoke during pregnancy, and the most affluent groups. And this is part of the reason why there's such a big difference in health between the rich and the poor. So what interventions work during pregnancy? There's good evidence for counselling, and there are specific forms of counselling which have been shown to be really helpful. There are others that have been shown not to be. Opt-out carbon monoxide breath testing has been shown to be a good way of drawing more women into smoking cessation services. So that this means that everybody gets a carbon monoxide test at maternity booking, and those women who have a test which is, I think, above 4 parts per million automatically get referred to smoking cessation services, and an attempt is made to contact them and talk to them about their breath test, and if they admit to being smokers, then to help them to try and stop smoking. That seems to be a much better way than asking women, oh, you say you're a smoker, is it okay if we refer you to the smoking cessation service? Where many women at that very busy appointment at maternity booking refuse or decide they don't want help at that point in time with their smoking. Incentives have been shown to be a useful adjunct, and there are certain self-help interventions such as SMS, sending SMS messages to support women that have been shown to be helpful. Interestingly, what only may work is nicotine replacement therapy. So we use it very freely in the UK. We don't use bupropion at the moment, but we use nicotine replacement therapy very freely. A lot of other places don't. America don't, as far as I know, and also Australia don't. So we use it. There isn't a lot of evidence that it works. And what doesn't work is certain types of counselling, motivational interviewing. I think motivational interviewing is a good way to start talking to people, but it doesn't on its own make any difference to whether they quit smoking or not. And similarly, interventions that offer physical activity support by way of, say, gym membership and so on, doesn't seem to make any difference to smoking cessation in pregnancy. So if we look at interventions in Scotland, before there were good cessation programs for pregnant women, about 10% of women's used smoking cessation support, and only 3% quit between maternity booking and the end of pregnancy. Certainly, cessation programs which include counselling have increased that, probably doubled that to 6%. Opt-out intervention so that you get more women in contact with smoking cessation service also have been shown to be helpful. As I say, motivational interviewing really wasn't particularly helpful, and there are certain self-help SMS messaging type systems that have been shown in trials to be helpful. If you look at, once you've got a cessation program that uses NICE guideline methodology, you probably get a 6% quit rate to perhaps an 8% quit rate of smoking during pregnancy. If you add nicotine replacement therapy to that, it maybe increases it by 50% to 9 or 10% of women quit during pregnancy. Physical activity really doesn't make any difference at all. So what about incentives? Incentive-based interventions include those interventions where women receive a financial incentive, and that's contingent on their smoking cessation. And we've used gift vouchers. Love to Shop vouchers are very easy to use, and yeah, we've undertaken a large pilot trial, if you like, called the Cessation in Pregnancy Incentives Trial. And this was undertaken in Glasgow, a single centre. And this came after a recommendation from NICE in 2010 for there to be a UK trial of incentives for smoking cessation in pregnancy. So we conducted the trial between 2011 and 2013. There were 612 pregnant smokers, so it was quite a large number of women. Both trial groups were offered routine care, which is a well-organised smoking cessation service that was manned by cessation advisors and was well established. The intervention group additionally received shopping vouchers up to £400, and the vouchers were offered at 4 time points throughout pregnancy, which I'll go on to later to explain when those are offered. So the results of that trial showed that incentives were generally acceptable to both women and healthcare professionals. This was a study undertaken by qualitative researchers, and significantly more smokers in the incentive group. So 22.5% quit in the incentive group versus 8.6% in the control group. And that was validated by cotinine on the saliva samples. And the incentives were likely to be highly cost effective. So the cost effectiveness is worked out using quality adjusted life years or extra life years that are gained, as I described in the women gaining an extra year of life if they give, or 10 years of life if they give up smoking. In a similar way, health economic assessments are done using life years, and they adjust them for quality, so that if you have a disability but you still live a year, that might only be half a quality adjusted life year, if that makes sense to you. So with incentives, we showed that each extra quality adjusted life year cost £500, and that's cheap in that NICE agreed to new interventions going forward for the whole of the NHS if they cost up to £20,000 per quality adjusted life year. So it's very much less expensive than the upper limit set by NICE. For women who couldn't quit smoking without incentives, we calculated that there was an increase in birth weight of 145 grams, which is about 5% of birth weight. We also had an indication when we phoned women up 6 months after birth that still 15% had stayed quit in the intervention group, compared with just 4% in the control group. Now, everybody always worries about gaming, and so the cotinine assay that we did, we had a check on that by collecting blood samples during the last part of pregnancy, and we showed that 20% of women gamed the cotinine assay, but what that meant was that 80% of women certainly hadn't gamed that outcome. So 80% of women were telling the truth, and their incentives were paid appropriately. And it was interesting that the gaming actually was the same in both the intervention and the control group. So both groups gamed. And for me, it seems that women game because they want to be seen as good parents to be, and they want to show that they have really given up smoking, even if they've had a cigarette or two a few weeks before, and that's why their bloods showed a higher level. So yes, so this is how the incentives were spent. That's one of the advantages of using Love to Shop vouchers, that they tell you where all the money has been spent. And as you can see, the largest spends were in Argos and Iceland. And of £53,000 given out as incentive, over £51,000 was spent. In some other interventions for smoking pregnancy, only about half the vouchers are actually spent. So you can see that women found these vouchers useful and worthwhile, and they used them. So if we go back to comparing the interventions, so those at the top are the same. But if you look down the bottom, so with a good cessation program, you might get 6 to 9% of women quit. With the incentives, we got 22.5%, so we're almost tripling the number of women who are quitting, whereas something like NRT, if it works, probably only makes a 50% improvement from 6% to 9%. So it seems from this one trial that incentives are very effective. We got a lot of bad press around the incentives trial, and yeah, that was difficult to cope with. So that left us at the end of 2013 having shown for the first time that financial incentives as an adjunct to a good smoking cessation service help pregnant smokers quit. But we needed to have more robust evidence because the intervention is very controversial before policymakers like NICE would change their advice to include routinely financial incentives. So we're in the process of undertaking a multi-centre trial in different geographic areas in the UK with varied population groups and varied smoking cessation services. As I say, that in Glasgow was a very good service, and we aim again to give up to £400 of shopping vouchers. And both groups receive standard NHS smoking cessation support, whatever that is in the area where the study is being undertaken. We started this study in September 2017, and it will go on until November 2020, or perhaps 3 months later. There are going to be 2 to 4 centres, and enrolment we aim to end at the end of 2019, recruiting 940 women, and we'll be following them up till 6 months after birth. There's a process evaluation and an economic evaluation. So the process evaluation really looks at all the different services and how the intervention works with lots of different services. And the economic evaluation is just to make clear how cost effective the intervention is. This is how we give the vouchers, and this is really my only experience of how vouchers are given. So we give a £50 voucher if the women attend their first meeting with a smoking advisor and set a quit date. A second £50 voucher if their carbon monoxide confirmed quit 4 weeks after that quit date, £100 3 months after the quit date, and a final £200 voucher towards the end of pregnancy, 34 to 38 weeks gestation, again confirmed by a breath test. Both groups, the incentive group and the control group, also receive vouchers for taking part in the study. And this is just really part of the trial process to make sure we get hold of all the control group at the end. The recruitment sites to the present are Lanarkshire, Belfast and Wessex. And what our next steps are to complete this trial, and we aim to include the results in the 2021 update of the NICE guidance for smoking cessation in pregnancy. There is a large real-world evaluation going on in Manchester of using financial incentives in pregnancy. And this evaluation also includes a trial of adding incentive payments after birth, because you will know better than me that many women who give up during pregnancy just start again as soon as they give birth. And so there is a trial going on, or just starting, looking at whether a further incentive after delivery would help with that. Why do financial incentives work? I was asked to give my view on this. Prior to incentives, 10% of pregnant smokers engage with cessation services in Scotland, and only 3% quit, so a third of them quit, which is fairly standard. What incentives do, to my mind, is increase the proportion of pregnant smokers who engage with cessation services from 10 to maybe 20 or 30%, and therefore subsequently double or triple the proportion who quit. So you're just drawing more people into the service. And I can show a little evidence for this. This is the new service set up in Glasgow. Prior to incentives, the 6-month period from the 1st of July to the 31st of December, there were 722 referrals and 154 women set a quit date. Incentives were commenced on the 9th of July 2018, and with incentives, the next 6-month period showed that the referrals had increased to 1,085 and the quit dates had increased to 213. So that already just in the first 6 months of incentives, before it becomes commonplace and embedded, there's already been a 40% increase in the number of women who set a quit date. So I think that's me. Thanks.
Thanks, David. That's really interesting. I'm just going to take chair's prerogative and ask you a quick clarifying question. Your slide where you were showing the number, go forward again to stop. So that prior to incentives, only 10% of pregnant smokers engaged, and 3% quit. Is that 3% of the 10%, or is that 3% of the pregnant smokers quit?
3% of pregnant smokers, so a third of the 10% quit.
Yeah, so about 30% of pregnant smokers were quitting, and your analysis is that
30% of
the people that went into the service.
Yeah.
Sorry. And so what's really interesting is that the incentive schemes are increasing the number of people who you can get into contact with an effective service, and then that's improving outcomes longer term. Yeah, interesting. Okay, we've got a bunch of questions that are coming in, and we'll take those, I think, with the panel. And we're going to be joined in the panel by Jane Coyne from Greater Manchester, so we'll be able to talk a little bit more about that scheme that you mentioned, David. So that will be excellent. Thank you for those people who've already posted questions. Do please keep doing so. Right, so we're going to move on to Fran Frankland, our next speaker. So Fran is the co-creator and project manager of various smoke-free pregnancy schemes, I think. And Fran is going to talk to us very much about the kind of pragmatic side of putting incentive schemes in place. Over to you, Fran.
Hello, can you see my screen all right?
Yes, we can. And we can hear you nice and clearly as well. Lovely,
I've got my new headphones on. Thank you, David. You gave us a really good lead up to what I'm going to be talking about. I'm going to give you a brief sort of outline of the history of how the supporting a smoke-free incentive scheme was set up in the Northwest and some of the results, and then how that's been utilised or implemented in Greater Manchester. Before I go any further, lots and lots of people were involved in the development of this scheme, and I haven't been able to name them all. So my apologies to anybody who may be listening who was involved and I don't mention your names. So in terms of the scheme that we're going to be looking at, I'm going to give you the detail of now. It was designed initially and trialled in Blackpool, where, as most people know, we've got a very, very high rate of smoking in pregnancy. And initially it was resourced by some money that came out of the Department of Health. And when it arrived in public health in Blackpool, we actually set out to prove that it didn't work. And we found that we couldn't do that. It kept working. So we realised that we needed to really hone into it and make sure that it was an efficient scheme. The other thing that we were also finding was that the incentive scheme was offering us a real opportunity to apply a level of scrutiny onto practices around smoking in pregnancy, cessation services, referral services, and also on the data, which was very, very useful in terms of understanding the situation was in Blackpool and what we needed to do about it. When we had trialled it in Blackpool, Healthier Futures in Manchester picked up the baton and rolled it out over the Northwest and did some evaluation. So I'm going to look at now we're going to look at what the aims are of the scheme, what the detail is, what the payment methods are, what some of the outcomes are, and then we'll go on to how it's being implemented in Manchester. So initially, the overarching principles of the scheme are to improve the women's health and to reduce the risk of harm to her unborn child. And the scheme is also designed to enhance support and incentivise pregnant women to set a quit date, to achieve a CO validated 4-week quit, to then sustain their quit temp throughout their pregnancy with enhanced support from whoever at the in that locality is providing their cessation support, and also to provide support up to 12 weeks postpartum. And this was quite important to us in order to try and understand that maybe once the baby was delivered, that might be quite a pinch point around relapsing. So we wanted to have a look at that. And within the scheme, we also included the support of a significant other as well. So when the woman came into the scheme, she could recruit a significant other, and I'll pick that up in a minute. Okay, just one thing I do have to add as well is that we did do this in 2010. We started it around 2010, and there was a higher smoking prevalence in pregnant women. And I think that a lot of low-lying kind of fruit, to use a term, was evident there. So we were getting some very, very quick results. My feeling now is that we're dealing with, much more addicted women who are more hardcore and are struggling more to quit. So eligibility for the scheme, the women who were eligible for the scheme was somebody who was pregnant, obviously, who was a current smoker or who had quit in the last 2 weeks, who was living with a smoker, having smoked throughout a previous pregnancy, was under the age of 20, or lived in an area of high deprivation and or high smoking prevalence. So the scheme was really directed towards inequalities and young smokers as well. So I hope you can see this. This is the pathway. Initially, because the scheme was aimed at achieving a 4-week quit, the pathway starts when they enter the cessation service. It's not based back into maternity, but I'll pick that up again a bit later because some services are provided by maternity. But where they were referred through, they were offered the scheme and CO validated, and to check that their criteria was there. They were then asked to sign a contract and asked if they'd like to pick up recruit a significant other. Now, the significant other is somebody who does not smoke and has to be CO validated in order to prove that they are a non-smoker. But that non-smoker, or that significant other, could also be somebody who wanted to do a quit attempt at the same time, because we did know that a lot of the women, their partners, it was very difficult for them to quit because they lived in a household that had another smoker or their partner smoked. So we gave an opportunity for that significant other. That significant other also signed a contract, and in the contract it laid out what was expected throughout the whole scheme up to 12 weeks postpartum, but it also asked them to sign for us to be able to go back to the Foundation Trust and ask us what they were recorded as smoking at time of delivery, so that we could see, knowing that the woman had gone all the way through her pregnancy and had not smoked through CO validation. And what we wanted to do is check that against the records of what the Foundation Trust had recorded them at. So they registered. In the first 4 weeks, they'd meet face to face, and each week they would receive a £10 Love to Shop voucher. Then each month post the 4-week quit, each month they'd meet, they'd be CO validated, and if they were still smoke free, they would get a £20 voucher. They're Love to Shop vouchers, the same as the ones that David was using. At time of delivery, around 36 weeks, again, they were CO validated and recorded as a non-smoker or a smoker, depending. And then postpartum, 4 weekly contact with CO validation, and each week the woman would get a £20 Love to Shop voucher. And then at the end of the 12 weeks, if the the significant other was still smoke-free, which they would be if they were a non-smoker, but if they were quitting, they'd also they would have been CO validated all the way through the scheme. They would receive £60 in Love to Shop vouchers. At any point, if a woman relapsed, she was offered an opportunity to rejoin the scheme, and she could only do that twice. So if she relapsed, she could go back into the scheme, but if she relapsed for a second time, she could not go back in the scheme, but she was offered general stop smoking and pregnancy cessation advice from her local service. So conclusions that we came up with the scheme then was that we recognised that the scheme enforced the evidence that incentives did work, and I'm going to give you some figures in a minute. And we knew that targeting financial incentives and combined enhanced support was more effective than the Stop Smoking service, which David has already shown us some evidence as well. We also found that the incentive, if we focused on sort of kind of more challenging situations, it really supported our public health priorities, but it also addressed inequalities, and we were picking up women that may not otherwise have engaged with the Stop Smoking services. And what we did find as well is, interestingly, when we came back and asked the women what they felt about the scheme, the actual CO screening all the way through the pregnancy was very, very important to them, because it was something that was very physical and tangible for them to see and reinforce them their quit and their Stop Smoking. It also allowed the advisor something to be able to say, you know, you've done a really, really good job here, well done, and here's the evidence to prove that that's the case. We also found that we got an increase in smoke-free homes, which was providing extended protection for other family members as well. And our database, we were collecting information about how many children under the age of 16 the woman was living with, how many other adults that may be smoking in the household as well. The presence of the SOS was also evidenced as being really supportive and contributed towards the quit for many of the women. And maintaining the postpartum provided additional benefits, and we found that this was also effective around breastfeeding as well. I was going to mention just then, sorry, I have to turn the slide, but I'll leave it there, around gaming. We did within the scheme have lots of discussions. We met quarterly with all the localities that were doing the scheme and asked them what was going on, and gaming did come up quite often. And because we were only CO screening, it was very difficult for us to know whether anyone was gaming. But what we came to the conclusion is that if somebody was gaming, then we couldn't do anything about it, but we knew that they were going to be in contact with a specialist advisor every month up to 12 weeks postpartum. So they were still getting that information, but we didn't come across any evidence of anybody that was actually gaming the scheme. I'm sure there was, but we didn't. So in terms of from the previous schemes, I've used data from 680 women. These have come off roughly around 12 different schemes. They're all exactly the same. And this is where the data is complete. So of the 100% of women who engaged with the scheme, we found that 472, which equated to 70%, achieved a 4-week quit. Which was really phenomenal when we compared that with the local Stop Smoking data. And then of the women who achieved their 4-week quit, so we're going to be taking out the ones that didn't achieve their 4-week quit, 60% of them were still quit at 16 weeks on the scheme, which is the standard end date for provision for supporting pregnant women in general service. And then the total of women who actually achieved their 4-week quit, who were still quit at 36 weeks gestation, was 67%, which was very, very different to what the local Stop Smoking service was providing us, was shown through general services. So if we then look at the targeting inequalities in young mums, 65% of the women, 65% of the teenage mums that were recruited achieved a 4-week quit, and 69% of the routine and manual unemployed identified group of recruited women also achieved a 4-week quit. So that's quite a high quit rate within both of those groups. The percentage recruited within the identified cohort who was still quit at 36 weeks, and this is from where they were recruited, 43% were still quit at 36 weeks, i.e. delivery, and then 21% of the recruited within their cohort was still quit at 12 weeks postpartum. The figures are quite similar with the groups, but what we were identifying was that we were hitting the targeted group. What we did find difficult was that we were finding that we were unable to find any data that we could compare with, because both within NHS Digital Local Stop Smoking Service, we couldn't break it down into the groups with pregnant women. So we compared it with the whole population of stop smoking. So progressive outcomes that we found between 2010 and 2016 is that the total percentage of the 680 that recruited, 6.4% of them were teenage mums and 67 were routine and manual. And the percentage of women recruited who achieved a 4-week quit, which we've already looked at, was within those groups was specifically high. The percentage of women who achieved a 4-week quit and were still quit at 36 weeks, we've also looked at, and the percentage of women who were quit at 36 weeks and then remained quit up to 12 weeks postpartum. So this is the group of women who have got right up to delivery, had the baby, they're still quit. Of them, 48% of the teenage mums who were quit at time of delivery were still quit at 12 weeks postpartum. And same for the routine and manual group, or never worked or not worked in the last year, 55% of the women who were quit at time of delivery remained quit at 12 weeks. But there are lots and lots of different variables that are within there that can contribute to a woman who maybe doesn't maintain a quit or will relapse through that. And that's through all sorts of different variables, such as how the service is provided in the area, the geography, how are they identified as a smoker within their booking appointment, lots and lots of different variables. So the data is really good, but there's a lot of intelligence around there that would have an influence on outcome. So moving on to the Greater Manchester Smoke-Free Pregnancy Programme, what was becoming really evident was that if we could stitch 3 evidence-based programmes together and lay this over the whole pathway for smoking in pregnancy, then we know that, one, we'd be working to nice guidance, we would be doing everything that we know possible to be able to support a pregnant woman to quit. And a target was laid down of 6%, to reduce it down to 6%. So what we've done is, I haven't done this, I mean, Jane, who's on the panel, and lots of people in Greater Manchester have worked extremely hard, is we stitched Baby Clear. And for anybody who doesn't know what Baby Clear is, it's a programme which is based on NICE guidance around effective CO screening and a positive consent opt-out referral to the Stop Smoking Service. And it covers every angle and ensures that every woman is CO screened and effective referral is taking place. Then we have the incentive scheme within the Stop Smoking Service, the cessation service, and also stitched in the risk perception intervention, which is quite a hardcore intervention for women who are not taking up their invitation to meet with a specialist advisor around smoking in pregnancy and are continuing and are identified as continuing to smoking through the pregnancy. So they're offered another opportunity to speak to a specialist and understand the impact that smoking is having on their pregnancy. Okay. So within Greater Manchester, the results that we are currently finding at the moment, and the scheme is ongoing, that compared with the Greater Manchester NHS digital outcomes for March, for 2017-18, 24% of the women who are reported in NH Digital achieved a 4-week quit, whereas within the scheme, within the first year of the incentive scheme, 57% of the women were achieving a 4-week quit. Also, we had a greater number of loss to follow-ups within the NHS Digital general stop smoking data, and only 7% within the incentive scheme. And then again, with the not to quit, we had a 32% within the pregnancy NHS digital data and 29 within the not to quit. And so there was a significant increase in the 4-week quit. And what we also know is with that as well is we recognise that more people were engaging, more women were engaging with the Stop Smoking Service, and we know that they're 4 times more likely to quit. This data was also allowing us to understand around loss to follow-up. What was this loss to follow-up? Is this something that is just cultural that happens, and we'll contact the Stop Smoking Service, have an appointment, and then not meet again? Or was it a data recording issue? We also needed to ask questions. Within Greater Manchester, there are 8 different areas. Are they all recording it exactly the same? Are they using the same criteria? So what this intelligence was now offering us an opportunity was not only were we getting increased 4-week quit, but we were also now able to investigate how data was being recorded and making sure that everybody was doing it consistently across Greater Manchester. It's quite a complicated slide. But each area has its own issues. But what you can see with here is that, and if I pick an example of Bolton, 84% of Bolton were achieving a 4-week quit within the scheme. Bury, we had 38% who were being lost to follow-up and only 10% in Bolton. We have to take into consideration as well within this data that we're getting from Greater Manchester that the implementation of Baby Clear and the incentive, not the incentive scheme, with Baby Clear was done on 3 phases. So you had cluster 1, cluster 2 and cluster 3. So we expected to see cluster 1 go ahead and cluster 2 and cluster 3 as they came on to start moving up in line with cluster 1. The best result, the best quits were in the areas that we were also identifying that where the specialist service was being supported by the midwife and by midwifery support worker. What we were finding was where a referral was going out of the Foundation Trust into a stop smoking service that may be being provided by a third sector provider, it was delaying the process of getting people into the scheme. So we're finding that was much more loss to follow up there because there was a longer time between being identified as somebody who smoked and being picked up by a specialist advisor. Where it was a midwifery support worker, they might be picked up in 5 minutes. Whereas when the referral was going out of the Foundation Trust, it could take up to 1, possibly 2 weeks. So where were the pinch points for the relapse within the incentive scheme? And you can see very, very clearly that the majority of loss to follow-up and relapse and exit happened within that first week, the first 4 weeks, and which I suppose could be expected. But one of the great things about this is that as soon as we started seeing this within the network meetings, which is where all the specialist advisors, the midwifery leads and the commissioners meet and we discuss this data, drilled in onto this 4-week quit. And now there is a drive to put some insights in there so that we could work out what is happening in that 4-week quit where we're getting such a major drop off. And if we could reduce that, we know that the evidence is if we get them beyond the 4-week, then we are far more likely to get a smoke-free pregnancy. I haven't got the time in front of me. Sorry, there's something in front of it. So if I'm going over,
you've
Hazel,
got a couple more minutes, Fran. Just
oh, that's brilliant. I've only got 2 slides left. Yeah. Okay. So now we're just looking at the first trimester. There's loads of data that comes out of the scheme, but what's interesting here, which we can see, is that we've got Bolton and Bury, we know they were in cluster 1, so we can, Rochdale and Oldham, who are in the middle. The pink section is where the referral has come in the first trimester, and that is our objective. The sooner we can get the woman into the specialist service or getting specialist support, the better. And you can see Oldham and Rochdale were in cluster 1, and they have rocketed ahead, whereas Bolton and Bury and Tameside are in cluster 2 and cluster 3. So we would expect to see in the next few quarters that they will start referring much quicker into the first trimester, which is incredibly important to make sure that we capture at that point. So finally, in my last few seconds, we know that it's offered just a sample, but we know that the enhanced support for pregnant women to remain smoke-free during pregnancy reduces the harm to her and her unborn. It reduces the cost to the NHS, and it reduces complicated births. It increases low birth weight, reduces acute and long-term poor health, both mother and child, and reduces the need for neonatal care. And we are finding that increases smoke-free homes. It offers a great opportunity to scrutinise the SATOD data and to get some consistency across the area for all women in the Greater Manchester area. And it generates a significant statistical insight into who is smoking during pregnancy and allows us an opportunity to build appropriate interventions. Thank you.
Thanks, Fran. That was excellent, and lots of specific questions coming through. So I'm just going to invite members of, I'm going to introduce rather the two other people that we have joining our panel for our discussion session. So we have Joanna Feeney, who's the Stop Smoking Service Manager at South Tees Stop Smoking Service, who is going to join us for this Q&A discussion, and Jane Coyne, who's the Smokefree Pregnancy Manager across Greater Manchester. So Jane, we've obviously heard quite a bit there about the scheme in Greater Manchester. Joanna, I wonder if you could just briefly say what you have in South Tees. Joanna, we might need, have we unmuted our speakers? Joanna, can you hear us? Okay, we'll come back to Joanna. Let's start with, oh, hello, Joanna, is that you? Okay, we'll persevere.
Hello, can you hear?
Oh, you're dipping in and out a little bit, Joanna. Try again. Okay,
we have. I do apologise. Can everybody hear me?
Yes, we can hear you loud and clear. Could you just say a few words about the service in South Tees and what you have in terms of an incentive scheme?
So in South Tees, we launched the Supporting a Smoke-Free Pregnancy Scheme in June last year. So it's a scheme that we run with Fran, and basically what it involves is the incentives being paid to pregnant women in the form of the Love to Shop vouchers, and the incentive points are at 2 weeks quit, 4 weeks quit, where they'll receive a £20 voucher. And then every subsequent 4 weeks, a further £20 voucher throughout the pregnancy. And then we'll also provide a 12-week postnatal as well. And the scheme, again, very much similar to what Fran has just been describing, also includes the significant other to participate and support the pregnant woman.
Yeah, it's a really interesting aspect, and I think we might talk about that a bit more as we go through the questions. So I guess I just want to clear up a few things around effectiveness. We've got kind of a few questions here about the value added of incentive schemes. David, I might come to you first. We had a specific question about, if you already have a successful scheme in place, a successful service in place that's achieving sort of quit rates of around 30 to 60%. What's the added value of having an incentive scheme in place, given that you might already be achieving those kinds of quit rates for pregnant women?
I think specifically it just draws more people into the system, so that if you say you've got 30 to 60% quit rates, I don't think that's on all pregnant smokers.
Yeah.
That's on those people that engage with you. And so it's about drawing a lot more women. As I say, in Scott, you can, if somebody comes to you and they want to quit smoking and they knock on your door 6 times, then they're likely to quit. Whereas if you drag them in off the street and they've not even thought about quitting, those are the ones that are going to be much more difficult to get them to quit. And it's drawing a lot more of those people into your service, I think.
So it is about bums on seats, I suppose.
The number of people who quit. And I think that's what we're seeing, is you're just dragging a lot more people who wouldn't normally engage with services into services.
And a sort of a follow-up question to that, and I'll widen it out to others as well, is whether we would expect to see an incentive scheme work without this combination of behavioural support and medication. You know, what would our expectation be if you only had an incentive scheme and you didn't have the stuff that sits behind it in your programme and in the ones that Fran has talked about in terms of behavioural support?
Well, I think that's one of the things that we're going to hopefully be shedding light on in the study that we're doing at the moment, in that the service we used in our pilot study, it was a very well organised, good service that got hold of everybody if they could, and there are other services that are less well organised, and for instance, in Lanarkshire, we have a service that isn't a specific smoking cessation service for pregnant women. It's a generic service, and it's organised not in a tight way compared with the services you're describing, and those are what are available at the present time for pregnant women. So the key thing is to see whether it works in those less focused services to improve quit rates. My own feeling is that you probably need to have a good quality pregnancy service before incentives are going to make a big difference. I suspect that in less organised, more generic services, they may work less well, but we'll certainly be able to shed some light on that from the study we're doing at the moment.
Fran, would that be your experience too? I mean, you've been involved in quite a few schemes. You know, what's the reasons why schemes are less successful? I suppose that would be one way of asking the question.
It's really, really complicated, but I'll just go back to if you've got a very successful scheme, why would you put an incentive scheme in? It's really, really important to note that actually, if you've got a really successful scheme, that scheme is about, service, that's about your 4-week quit. And what we're looking here is up to 12 weeks postpartum. My experience is that a majority of women who go in the first trimester feel really groggy and find it a lot easier to quit because of the actual smoking. But once they get further into their pregnancy and they feel much sort of kind of healthier and more robust, they feel that actually smoking is going to be less harmful and they're more likely to relapse. And it's very, very difficult to look at the 4-week quit data and then compare that with the SATOD data. And the incentive scheme is, yes, it is about getting that 4-week quit, but then the incentive is about incentivizing somebody to continue to have the enhanced support from the absolutely brilliant and lots of specialist advisors out there who use forms of CBT and counselling and other interventions. And it's those interventions that can really, really make the difference. When we evaluated we called it a client-facing evaluation in the Northwest, a lot of the women came back and said it was actually meeting with somebody, being supported by them in a very, very highly trained, skilled specialist way, seeing a CO reading, which was very, very important. And actually that was almost more important than the incentive. So the incentive is to get them to that specialist service. I could never see that you would just give an incentive and no support. Back in about 2009, we used the tariffs to work out how much was it for a complicated birth and all the sort of bits and pieces that go with that. And we were finding that our average spend in the scheme was around £100 to £150 per woman and their SOS, but it was costing around £2,500 for a complicated birth and less than a week in a neonatal unit. So in terms of cost effectiveness, that was really good. Yeah. I don't think I've answered the question there, have I?
No, I think there was a lot in there, Fran, and actually it leads me really to the next question, because we have a number of people asking in different ways, this is all very nice, but where does the money come from, and how do we justify it? So I wonder if I could bring in Joanna and Jane at this point. How in South Tees, how's your model funded, and how did you go about securing that investment?
So one of the things we actually looked at was what was our success with pregnant women in the lead up to the period of this. And one of the things that we found was that we had a very good referral pathway into stop smoking services, but what we found was...
I'm sorry, Joanna, but we can't. We just
that
keep losing
actually
you. I think
it was getting women
Joanna,
to attend.
I'm sorry to stop you, but we keep losing you, losing the connection. So I think I'm just gonna move on to Jane for now because the connection is really poor.
No
I'm
problem.
really sorry. Jane, it's a bit different in Greater Manchester, but perhaps you could talk a bit about how you secured support for investment in the incentive model in Greater Manchester.
Yeah, so we're slightly different in Greater Manchester that we've implemented devolution in health. So obviously our health and social care budget is set very differently in how we choose to spend that. And then obviously the review from the National Maternity Services around better births allowed us to focus on ways of improving safety and outcome for women and our babies more locally, and actually allowing us to take that focus on smoking in pregnancy as a key priority. We got investment through our transformation fund, which obviously we've used to implement the local programme. So that's how we funded that in Greater Manchester. As we're going along with this scheme, which Fran has showed some of our amazing results that we've got going on presently, obviously part of my role is to review how we create sustainability for that going forward as well.
Brilliant, thanks, Jane. Okay, I'm going to ask a question about how the sort of added value of incentive schemes and thinking about some of these other outcomes. So we have a question about what data we have on the likelihood that women quitting with a significant other versus pregnant women quitting on their own. You know, what do we know about whether this type of approach is producing outcomes? Fran, obviously that it's a relatively new approach in Greater Manchester, but is there anything you can talk to on that about whether we're seeing different outcomes with the significant other involvement?
Within Greater Manchester, we haven't been running it a long enough time now because a pregnancy is 9 months' time, the scheme after about 2 years. But what we can definitely say is that there is almost certainly a 6% increase in the 4-week quit and smoke-free at 36 weeks, which was demonstrated by, and I can never say her name, Dontanelle, the Oregon research, which is actually the inspiration. I think it was right back in 2001, where over in Oregon they did a trial with a control group, and they actually had one with their significant other. And we're pretty much finding the same. So it's a minimum of a 6% increase. But obviously we've got variables there because we don't know whether, in the scheme, whether the significant other is somebody who's attempting a quit or somebody who is actually has never smoked or doesn't smoke. So it's quite a difficult question, but we are guaranteeing that at the end of the Greater Manchester scheme, we will have the data that we can give out, but we haven't been running it long enough to be able to come up with any valid or significant data as yet. But we are assured and are very confident that 6%, we'll get a 6% increase, definitely on the 4-week quit and most likely in the at 36 weeks. David, do you have anything to add to that?
No, we haven't done anything including significant others. We're just really focusing on trying to produce the evidence that actually financial incentives are cost effective around the UK, not just in one place.
And you, I know that we had relapse rates information in Fran's presentation. I'm trying to remember what was in yours. Have you looked at the postpartum experience of women who've engaged in the scheme?
Well, we only looked at it in our pilot study, and as I say, 3.5% quit in the incentive group, and at 6 months postpartum, there remained 15% who remained quit in the incentive group, whereas 8.6% quit in the control group, and that had gone down to 4% by 6 months after birth.
We've obviously got different schemes out there that have used different amounts of money as incentives and provided that money or those vouchers at different points in time. Dave, do you know very much about what we know about the optimum value of incentives for this kind of scheme, and whether there's good evidence to say you should do it in this schedule, or it provide more at the beginning or more at the end. What do we know about that?
I mean, I'm not aware of any good evidence in regard to that. We chose an amount, and we've stuck with that. Interestingly, Glasgow, who were our pilot trial area, have now set up their own service using incentives, and they've reduced the incentive payments to half the amount that we used. They are seeing an improvement, as I showed in I think my last slide, in the women that are coming through. But certainly Brenda Friel, who was the manager during the trial, I think feels that not as many women are coming forward and engaging with the services with the lower payment. I suppose all I would say is that everybody thinks the incentive payment is the most expensive part. It really isn't. The incentive payment, the counselling, even the giving out of the incentives, how you organise that system is time consuming and expensive. So I think people get too hung up about the actual amount of money, which is not what is. I don't know whether others would disagree with this, but for me, it's not a big expense as far as the rest of the service is concerned.
So, Jane, how have you gone about setting the level in Greater Manchester? And what would you advise other people to be thinking about as they're developing schemes locally and thinking about what value they should place on the incentives?
I mean, Fran's obviously a bit more open to this than I am. I think what we've done in Greater Manchester is followed Fran's previous scheme. So we've looked at, giving those incentives quite regularly in the beginning to try and increase that contact and engagement with women, so that they're kind of getting a little bit drip fed, if you like, so that women are encouraged to come back and see us. And then obviously lengthen the time in between giving an incentive as we get to know women and we've got them engaged. I don't know what your thoughts are in that, Fran.
What more would you say on that, and what people should be thinking about when they're trying to work out what they should do locally?
I think there was an incentive scheme in Derbyshire that I think got fairly similar outcomes, and they tapered their amount on the incentive. I agree with David. The other thing that you've got to take into account as well is not every woman gets the same amount, because they will join the scheme at different gestation. So actually it's really, really quite difficult to work out exactly how much you would give somebody, because if you've got a late booker and they join the scheme, they may only be on it for a couple of months before they actually deliver. So the actual incentive, the £20 that we give every month, or the £10 each month in their 4-week quit, is actually quite a small amount of money. I actually say that and I feel, actually to some people that's a lot of money. But it is the organisation, and yes, David is right, it is quite complicated to actually sort of get it all sorted out. What we found from the advisors that have come back, so they really like having the incentive, because it does allow them to incentivise somebody to come back to them, and for them to then be able to give the intervention. And it's the intervention that is the most valuable. I mean, it's priceless to some people, and so is the quit smoking. So it's actually quite a difficult question, that, because it varies. We have some women that will go through the scheme that might just get £20, and some that might end up with 200.
Interesting. So I have a question.
I suppose just to add to that, I think for me, Fran will agree or disagree with this, but for me, what the incentive actually does is it allows the therapist to actually do what they're there to do, which is to help somebody to quit smoking who wants to quit smoking. Whereas I think before incentives came along, or in places where there aren't incentives, half your time is trying to drag people through the door. Yeah. And that's a totally wasted time for somebody who's got a lot of skills in helping people to quit smoking. So if you like, it allows therapists to do what they're there to do, rather than try and do something which is almost impossible.
Well, that's interesting, David, because I was about to ask about who is providing information to women and how they're providing information to women about these schemes. And it sounds like it probably varies across scheme when women are communicated to about the programme and who gives that information. So I wonder if you could talk a bit about what you think is kind of optimal in terms of, should the information come through midwifery? At what point should women be informed about the incentive scheme to get the most from it? Fran, I don't know if you want to take that one on first.
Yeah, absolutely. No, I get, I love these words. It's all quite complicated. But from the point of view of Greater Manchester, the most important thing is, in the real world, the VBA, the very brief advice, and the CEO screening, the whole programme around the baby clear is the really, really important part. So in that point, we wouldn't expect the incentive scheme to be talked about at that point, because the most important thing is the midwife doing a CEO screen. And in the real world, and 20 years down the road, and cultural change, that's the most important bit. The other aspect as well, in terms of where we talk about the scheme, is that we have found that the majority of the difficult press that we haven't received a lot, but what we have, the difficult press has come where we've almost said, well, everyone can go out there and all the midwives tell them that they got this incentive scheme, and then it gets out into the public. And we've had to handle some fairly tricky situations as well, is that if a midwife doesn't realise that the scheme is no longer running, and she refers somebody saying, oh, go to the service, it's absolutely fantastic with brilliant people, and they'll whatever, and they get to the service and she's saying that you can get 200 odd quid or whatever, and she gets to the service and they say no, we're letting down our pregnant women. So when we talk about it is when they first are contacted by the specialist service after the referral has happened. However, we know and have confidence in a lot of midwives that do CEO screening, and where it is appropriate, we will say to them, if you want this in your toolbox and it is going to work and it's going to help, and you feel that that is going to enhance the likelihood of that person, that woman, having contact with the specialist service, then use it. But we will be very clear about that.
So the communication with women directly is one aspect of communications around these schemes, but several of you have alluded to the potential controversial nature of incentive schemes for pregnant women. Hopefully we've got Joanna back and a better connection. Joanna, I wanted to come to you and ask you a bit about how you might manage some of those media messages, political messages, when you're kind of securing sign-off for a programme, getting senior leadership and politicians on board and then communicating that to the public and the media. How have you gone about doing that in a positive way?
So, we've actually been quite good here in terms of that we haven't had any negative feedback. As Fran said, I think it's very much about how the scheme is sold, I suppose, to the local councillors, to the local organisations, midwifery, that actually this isn't a scheme where we are paying women to quit smoking. This is a scheme which is about engaging pregnant women. And on the whole, we've actually had very positive impact about it, because I think people understand the risks that are associated with smoking during pregnancy and the additional support that's required to help women to engage with quality evidence-based services, so that they can quit not just for 4 weeks, but throughout their pregnancy and also postnatally as well. Hello, can you hear me? Hello?
Oh, sorry, I'm talking. I'm carrying on talking, and I've muted myself. I'm so sorry, everybody. I've got a last few minutes for questions, and there's a few people who are asking questions about where services ought to be located. Should they be being delivered within midwifery? Would that be optimal, or do we want to see these incentive schemes being administered by more traditional stop smoking services? Fran, do you have a view on that?
I do have a view on that, but I think I'd like Jane to answer that one because
go on then, Jane. Sorry,
it's okay, don't worry. I think we're quite lucky in GM that we've got a varied set of circumstances where we've got different providers providing the service. But I think predominantly the evidence speaks for itself, where we have the specialist midwife and maternity support worker service providing the stop smoking support and incentive scheme. We're seeing quits of late 70s, 84%. Compared to our traditional stop smoking services. And some of the insights from the women have been, well, they wear a uniform, so they're within their, they feel like they're part of their care pathway, they see them in the same building. There aren't as many barriers to actually achieving some of those quits.
What about Joanna? Joanna, your service is delivered by the Stop Smoking Service. Would you have a view as to whether there would be a preference to have it delivered within maternity?
Yeah, so I mean, within South Tees, the Stop Smoking Service are currently, the specialist services what deliver the incentive scheme. We do have pharmacy and GP support within South Tees that pregnant women can access, but the incentive scheme is not eligible for women who are accessing within those. I think, you know, the experience that we have within South Tees is that actually it's about the flexibility of support, and in some areas where you've got maternity care assistants, there's a greater flexibility of support. And as Jane kind of said, if it's seen as being within the maternity care, it's not seen as being an add-on service, and there's less opportunity for women to disengage.
Thank you. We have lots of questions that have come through, and we haven't managed to get to all of them. Some of these questions relate to things which I think we can provide people with further information on. So we've had a few specific questions about the role of NRT. We had a webinar a couple of weeks ago about nicotine in pregnancy. We'll circulate the link to that webinar, which can give you more information on that. We've also had some questions about, you know, the types of training that would be most appropriate for advisors to have supporting pregnant women. So we will circulate some more information pointing you to some of the NCSCT resources and other things that might help you with that. And we've also had some questions from people asking about whether we know if there are incentive schemes available in their locality. If we can answer those questions, then we will. Otherwise, we'll put you in touch with your local stop smoking service, who hopefully will be able to answer that question. But I would say if you are uncertain about what's happening in your local area, then definitely find your local authority stop smoking service and ask them the question, because they really ought to know the answer. And if you don't get any further, then come back to us. So I'd just like to thank all of our speakers for their input. I think it's been a really interesting session. There is much, much more to talk about, and we could carry on for another hour, I think. But we will try to answer some of the questions that we've not got to during the session offline. We will be circulating our briefing over the next few weeks, which will hopefully also address some of these questions, and keep having these conversations about incentive schemes. I would also urge people to fill in our evaluation survey when we send this round, and again provide some more comments there about, you know, how you might be taking this forward locally, and any further queries or questions you have or resources you'd like to see from us to support this work. So I'll just thank our speakers again, and thank you all for asking such great questions and participating in the webinar so fully. Thanks very much.
Thanks a lot.
Thank you.